continue to happen. So hopefully there will be minimal glitches. The Wi-Fi in my hotel room has been pretty good thus far. So knock on wood, that's going to continue for us. So I don't have a case for us to talk today, but I am going to kind of review what is a safety bundle. Why do we need to use safety bundles? We'll take a bit of a break just to answer any questions at that point. And then when we'll restart back, we'll kind of talk through some implementation steps. And I was asked to talk specifically about venous thromboembolism bundles this time, because that has been your last several presentations has been related around VTEs. So hopefully this will help kind of put some of that information together. So what is a safety bundle? A safety bundle is a structured way of improving processes of care and patient outcomes. So in order to put together a safety bundle, there are experts from multiple areas in the healthcare and quality improvement work, and they gather all of the best practices, all of the multidisciplinary pieces and parts that will clinically address very specific conditions in the pregnant and postpartum patient. Now, there's safety bundles for non-pregnancy related things, but the ones that I'm most familiar with are all of the ones that we work on for our pregnant and postpartum patients. And I really liked this little graphic because I was like, this is exactly what we do, is that we define a problem, we analyze different pieces of that problem, we start establishing criteria, we start looking at, what are some possible solutions, and within that criteria and solutions is how might we measure that improvement piece. Then we decide on a solution, we implement the solution, and then you have to do the follow-up on the solution. And so within the safety bundle work that we do in the state, that is always a key piece of that. Now, I will say for South Carolina, we have implemented several safety bundles at the state level, but we have not done the VTE bundle individually as a state. I found this, why do we do what we do? Chris Petker, which we have met in the past, he has come down and been a speaker for the BOI symposium in the past. This is a quote from Creasy and Resnick's Maternal Fetal Medicine, but in response to review or in the course of maintaining practice patterns that conform to changing standards, it can be exceptionally useful to develop a series of protocols and guidelines delineating practice. And I know that as providers, both in the hospital and outpatient setting, you don't want to feel that your work has to become a cookbook, right? You don't want the protocols to be so specific that you can't use your own clinical judgment with that. And that is not what a safety bundle is about. The protocols are there to help provide that common foundation for all clinicians working with patients in a way that's structured in how do we approach the patient, but it certainly does set some standards of practice. It does set some kind of safety-based, based on the history of research and what the science tells us and what those outcomes look like, how we can then approach these different problems that we have. So that's really why we use safety bundles in the obstetric world. So I like to think of it as we have these puzzle pieces, right? And so how do you approach a problem when you're the one putting a puzzle together? So recently over Easter, my oldest came home and we attempted to put a huge jigsaw puzzle together. And we approached it in very different ways. And so we both initially started putting things in piles of colors. So we had our piles of colors, and then he was very super focused on finding all the edge pieces and making that outline of those edge pieces, where I was like digging through and looking at the picture and trying to see, oh, look, there's the bunny's eye that I'm trying to put together. And so we have very different approaches to this kind of process. And we were both working at the same goal of trying to make the puzzle. And then when we were kind of bumping elbows with each other, we were like, okay, we got to come up with a better plan. And so that better plan was we had already separated in the colors, and then we started, and this isn't my table by far, but this was kind of what we decided. Okay, we're going to work together, and we're going to go ahead and you really feel comfortable in doing the outline, so I'll follow along with that, and we'll do that, and then we'll start kind of going from there. And so it was really kind of fun. And as I was thinking about safety bundles, and I was thinking about how to present this today, I was like, that kind of puzzle picture really makes sense. There's lots of different ways to approach these different safety issues that we have with our patients. And no one way is the wrong way, as long as the ultimate goal is we're doing things to create safer space for our patients and increase our outcomes. So I was asked today to talk about our VTE bundles for our U.S. data. So U.S. pregnancy-related deaths. So remember, pregnancy-related is during pregnancy or up to 1 year postpartum, regardless of the end of that pregnancy, from a pregnancy complication or a chain of events initiated by the pregnancy or a condition made worse by the pregnancy. For what are these causes? So this is kind of some of the most up-to-date data that I was able to pull. It is a little more difficult to find some of this information, but you can see that embolism still is one of the leading causes of pregnancy-related deaths in the U.S. For our South Carolina data, we were able to make the comparisons from our data from 2018 to 2021, and then 22 to 23. And in those case reviews for the pregnancy-related deaths in South Carolina, in 22-23, we had 0 cases of VTE, but previously embolism was listed as one of the leading causes for pregnancy-related deaths. So just because we didn't have any cases that were pregnancy-related does not mean that the problem is solved, and it does not mean that the problem we don't need to worry about it anymore, because that is not at all what this data points to. And so as we'll kind of address that later on when we get to some of the implementation pieces. And just by comparison, the pregnancy-related deaths for 2021, embolism, the amount dropped down. It was 8.7 previously. It's now at 5.3 for the 2021 data. So there is a decrease. And I do think it's because this particular safety bundle has been around for a very long time. So a few basic reminders for all of us in the clinical space or non-clinical space is that pregnancy in and of itself, and I know from the last couple of presentations we've made this really clear, is a very prothrombotic state. And part of that is related to just the physiology of having a giant uterus that is going to press on all of those major vessels and decrease that blood flow capacity. There's also the piece of the after delivery, the woman's body needs to be set up in a way that she doesn't completely bleed out. So we have all of these pregnancy-related changes and postpartum-related changes that's supposed to help us not to be able to have a hemorrhage and to bleed out, but it does have other issues that go along with it. So we have other risk factors that are not just specific to pregnancy. So you have a woman who's been hospitalized in the antepartum period. She could have had some previous history of some kind of vascular trauma or current infection, obesity. Even when we start getting into that preeclampsia picture with severe features, our pregnant individuals who are greater than 35 years old, history of cesarean or current cesarean delivery. Oops, I have greater age twice. Sorry about that. Our obesity. And then all of those kind of inheritable or acquired thrombophilia issues that we have where you have an increased capacity for your clotting factors. So when we look at general safety bundle components, I have to talk about AIM first. So that's on your right-hand side. So AIM utilizes the 5R component. So that's readiness, recognition and prevention, response, reporting and learning systems, and now, which is, and I can't believe I forgot to leave that on this, was respectful care. So there is that 5th R. The CMQCC takes the same approach as you can see, but they just title those different pieces and parts a little bit differently. And I will say that the VTE bundles for both AIM and CMQCC are older bundles, and we'll get into that in just a second. But from CMQCC, if you were to go dig into their bundle, they're going to really, first part is appropriate risk management assessment. Next are how do we prevent that clot from happening in the first place? And then what are strategies for management once we do have either high risk or we have components of their signs and symptoms of having a clot formation. So the review on all the medications, review on the algorithms, what is that post-discharge care recommendations. So, like I said, the VTE bundle was one of the older bundles. The Council on Patient Safety in Women's Healthcare, or Safe Healthcare for Every Woman, was the first iteration of the work that's being done by AIM. And this safety bundle, by comparison to the way that the bundles are presented now, there is a ton more implementation strategies, data components that go along with it for support for actually implementing bundles. I will say that this specific one, the VTE bundle, has been kind of retired at this moment. It has not been updated since 2015. I had it saved from a long time ago, so I was able to pull this for you. I think you can probably still find it on Google if you wanted to, and if you just put in, AIM safety bundle for VTE, a PDF will pop up for you. That's not to say that if you decided that you needed to do this work because you have noticed a pattern in your patients, that you can't utilize this process of that readiness, recognition, and prevention, response, and reporting systems and learning. When we look at these, the readiness is every unit. So every unit means that anywhere where the pregnant or postpartum patient may present for care where that risk assessment should or could be done. The recognition and prevention is for every patient that we touch. The response is for every unit to be prepared to take care of these patients when these events happen. And then that reporting is the data, how are we doing? Are we actually using standardized metrics? Are we usually actually following the algorithms that have been set up by your facility? Now, CMQCC did their first version in 2018, but they did reaffirm it in 2025. So there is a lot of information that's available on the CMQCC website. They are kind of the leaders in maternal safety bundle work and toolkit work. So I'm going to focus most of the time today on what CMQCC has, only because it has the most updated information. But again, the readiness is having that risk assessment tool in the outpatient setting and in the hospital and in any kind of postpartum follow-up. Recognition really focuses on applying those standardized tools to all patients, every patient, at specific points designated by your policy and protocol. And then how do you utilize those tools? What patient education are you doing? And then what education is being provided to the clinicians in and out of the hospital on how to use the risk assessment, and then what are we doing about it for management. Response is what you actually are doing, and like I said, then reporting and learning systems is your data collection component. There are some implementation guidelines and resources that you can find. This for the kind of AIM version of this, again, has not been updated since 2018. And you know, as well as I know, that if you're doing any kind of CME or nursing
Oh, Michelle, we lost your sound. Let's see. Dr. Campbell, can you shoot her a quick text in case she can't hear me that we've lost her sound?
Yes, I'm working on it.
Thank you. Thanks, everyone, for bearing with us. Oh, okay. Oops, hold on.
I think she's going to rejoin us.